Welcome back to the channel. Today, we are joined for a special treat. Dr. Adam Cifu, professor of medicine at University of Chicago and general internist extraordinaire, also the winner of more teaching awards than I can count. He is going to give us a lecture on reversal and implications during the pandemic and beyond. And then afterwards, we're going to do a Q&A with members from my research team. I look forward to a really interesting discussion. Thank you so much, Adam, for doing this.
Yeah, great. No, happy to. And thanks for inviting me. Feels a little weird to give your crowd a reversal talk. I'm sure they hear it from you all the time, but I'll sort of see what it sounds like coming from my end. So let me get things going here. And I had a bunch of slides I thought I'd just walk through. Obviously, feel free, honestly, to interrupt me, but I left a lot of room at the end just to chat. And this talk goes sort of through medical reversal at the beginning with some of the things that I'm kind of most interested in, and then finishes up with just like how COVID made me reflect on medical reversal and evidence-based medicine. And those are sort of, I gotta say, like ill-formed thoughts. They're like the things that I'm still pondering when I'm out wandering around, and try to formulate those onto a few slides, but it's mostly to stimulate discussion and see sort of what you guys think about all that. My disclosure is we obviously have a book on reversal. It seems ridiculous to call it a disclosure since we make basically no money on it. And what we do, we have to split. I've got nothing else. And I'm also, unlike many of you, most of you, I am definitely not a researcher. I see myself as a clinician, an educator, and a critic of other people's research. And as you all know, that tends to irritate a lot of people. So what is reversal? Reversal is just when a currently accepted medical practice, like something we're actually doing, is overturned, found to be no better than the therapy it replaced, or maybe even sometimes found to be no better than no therapy at all. That usually happens to orthopedics, I think. And it occurs, overall, just because the practice was adopted without a robust evidence base. We can sort of just end the talk with that probably, but we need to go into further detail. Here's Cafe Korea. Vinay and I think we had our first reversal talks at this place, which is unfortunately closed. It was like such a wonderful restaurant. It made me happy to pull up the slide. I like to talk, when I talk about reversal, I like to sort of put it with all of the other ways that our practices change in medicine. And the first thing is replacement. Replacement is like how we want things to happen, right? We have an accepted practice. We do studies, we develop robust data. It shows us that a new practice is better than what we're doing, and we adopt that practice. That's like how medicine progresses. That's what we all want, right? Reversal is we have an accepted practice. We have data of some sort that supports a new practice, so we adopt that new practice. And then only later, after we've deployed this new practice to thousands, hundreds of thousands, maybe even millions of people, we find out that that actually doesn't work. And we should go back and use the accepted practice or stop treating people at all with that. Both of these are very different from just negative studies. And a lot of people try to sort of pitch a negative studies as reversal and say, like, reversal is nothing interesting. It's just negative data. That's how science works. And that's not true. If you have a novel practice, but you haven't deployed it to the population as a whole, and then you have negative trial data, that's how things are supposed to work. That's how you figure out that something that you thought was a really good idea doesn't work, and you're kind of back to the drawing board, right? You're going to say, okay, we're going to go back. We're going to try to figure out what do we need to change about the practice? What do we need to change about maybe the population that we're giving it to, and sort of do the right thing. You're going to be outline what I talk about. I'm going to throw out one example of medical reversal, just sort of, one of my favorites, to let you all know what we're talking about. Talk a little bit about frequency, which is some of the research that probably some of you guys have been involved with. Harms, talk about why we care about this, why are people harmed, and causes, give whole talks about causes. I just sort of picked 4 things that I find interesting that I thought I'd talk about. And then we'll kind of get to COVID at the end. And that should be pretty quick, I think. I learned early on, I think the first talk I gave on this after Vinay and I had sort of worked it all out was a grand rounds at Christ Hospital here in Chicago. And I was just totally attacked because they thought I was this person coming and just sort of disrespecting them and lecturing to them about everything that they were doing wrong. And I had to make it clear that like, this is part of medicine. We all do this. We all make this mistake. And so I generally sort of tell people like, hey, reflect on something over your career that you've done, that you thought was right, that you believed in, and then you realized that it wasn't right and you had to pull back. And just about any doctor who's been doing this for any amount of time has those experiences. And this is kind of an incomplete list, for me, right, of things that I've done, medications I've prescribed, procedures that I've referred people to, screening tests that I've done, that I've later sort of found out that, boy, I either shouldn't have been doing this at all, or I definitely should have been doing it in a different group of patients and certainly fewer patients. The example I always go to is atenolol and antihypertensive. I don't know why this is so important to me. I think just because early in my career, really popular antihypertensive, we use this on everybody. It was a trial standard. So if you developed an antihypertensive and wanted to get it approved, you had to show it was as good or better than atenolol. And I dug out this personal formulary, which was this stupid thing that I had to do as a medical student. It's dated December 30th, 1992. And it's all these drugs that we had to write up and tell about. And actually the fifth drug in here was atenolol. So I think I'm just attached to it because it's in my medical DNA. And atenolol, you basically never see it anymore. And it's because despite using it for 15, 20 years, it really doesn't work. The reversal began in 2002 with this LIFE trial, pretty famous trial at the time, huge RCT, 9,100 patients. They took patients, hypertension, some risk factors, randomized them to either a losartan-based regimen or an atenolol-based regimen, treated them for at least 4 years. And look at this endpoint, right? Death, myocardial infarction, or stroke, a real endpoint. It's not doubling of creatinine or something stupid like that. And the results are these. So it looked like this was a good new drug. It was just as good of atenolol as for controlling high blood pressure. But was sort of surprising that even though it was just as good at controlling blood pressure, it was actually much more effective at preventing the endpoints that we treat hypertension for, right? We don't treat people's blood pressure to lower their blood pressure. We treat their blood pressure to decrease their risk of heart attack, stroke, death. And so this was really replacement. This is right. We have a good drug, atenolol, and now we have a better drug, losartan. Well tolerated, does a better job at decreasing endpoints. The reversal came a couple of years later with a big meta-analysis where people were worried and they said, well, let's look at how atenolol actually does against placebo, and brought together all this data. And it turns out that atenolol really did nothing. No difference at all cause mortality, cardiovascular mortality, MI, barely, maybe a slight benefit in stroke. And so that kind of put the nail in the coffin for atenolol, but not surprisingly. I mean, atenolol, was prescribed for a good 10 years after this study. We'll talk about that a bit. It's actually not just atenolol, it's really beta blockers. This is a Cochrane systemic review from 2017, looking at data for beta blockers. And beta blockers themselves are not terribly effective as antihypertensives at decreasing the endpoints that we treat hypertension for. So certainly beta blockers shouldn't really be your first line antihypertensive. So how common is reversal? And I think it was Vinay's line that are we interested in this because it's really memorable? And when you have to change care, you're like, oh my God, I'll never forget this. Or is it common? And is it something we should really care about? And the truth is, despite everything we've done, we have no idea how common reversal is. There's no good way to study this. But I think what we figured out is that it's at least not rare. And 4 studies, which are sort of neat ways to think about this. The first one by an author who maybe shouldn't be named these days, was this one back from 2005 by John Ioannidis, which is such a sort of brilliant idea of how to get at this. What he did is he looked at about a decade and a half of really highly cited works, right? And these are works about medical interventions, and these are like really highly cited, right? Referenced over 1,000 times, like that's everybody's dream. Vinay, any of your papers cited over 1,000 times?
Not quite.
Right. So, all of what we want. And then what he did is he tracked the efficacy of these interventions over subsequent years. And what he found out is that 16% of these interventions were actually ineffective when studied again. 16% were less effective than were initially thought in that highly referenced paper. 44% were really practice changing. And 24%, we just accepted that these work. We're never going to test them again. This doesn't really tell us how common reversal is, right? It tells us how common reversal is among highly cited interventions. But it lets you say that, wow, this actually happens. May actually overestimate the percentages because maybe these were highly cited interventions because people were so surprised that they worked. But he begins to sort of lay the groundwork here. This was an article published in the BMJ in 2011. And, when you have a national health system, it's very, very, very important to figure out that you're spending your money in the right way. Christine, it sounds like that's what you spend your time trying to figure out. And they looked at 3,000 treatments, practices, things that were actually being done in the UK, and just looked into the evidence and said, like, how robust is the evidence backing these things up? And you'd see about 30% of them had a pretty good evidence base behind them. About 15% were either questionable or were actually likely to be harmful. And then 50%, there was just inadequate data behind. And so these are basically things that have already been reversed, and that 50% are things that are at least open to reversal if they were actually studied. And then we started working on this, early 2010s. First attempt was to look at all the articles published in a decade in the New England Journal to see how many of those represented reversal. There were about 2,000 original articles. When we got down to just the articles which looked at practices and just the articles that looked at established practices, we ended up with 363 articles to really think about. And it turned out that 40% of these were reversals. So if you were looking at an accepted practice and really tested it, it was almost, 40% were going to turn out to not be reasonable. Again, this is something which doesn't really tell you how common reversals is. This probably speaks more to the editorial decisions of the New England Journal than actually what we do. But again, tells you this isn't rare. This is kind of what the study looked like. 2,044 articles, about 2/3 looked at a medical concern. The other 1/3 was about sort of basic science research. I'm also not a scientist, so those were not interesting. 73% of those, so about 3/4 tested a new practice. Those are kind of the hot things, which always get into the New England Journal. 25% were looking at an established practice, 27%. And this is where our reversals lived over here. We worked on this at this restaurant, which was like Floriana in DuPont Circle. Remember this place? I had to dig up a picture of it. It was a bad restaurant. Anyway, and then the last one is an article that you guys worked on, and I was totally a gift author. Is that what we call it? When it's just like, here, we'll stick you in the middle here. Which sort of took the idea of the previous study and just made it much larger, much more robust, much better done. Looked at 10 years of New England Journal, not overlapping with the previous study. And then about 15 years of JAMA and Lancet, huge number of articles, and really a great effort at figuring out which were the reversals and going into a whole nother level of depth by saying, let's look at meta-analyses to make sure that the reversing articles have really stood up and stood the test of time. And it was an amazing number. So 396 other practices that were identified in this that had been adopted and then were found to be not effective. That came to be 13% of all the randomized trials published in 3 very different journals. So this is, I think, something we should care about. It's something which happens. It's something which affects our care. It's also important because when there's a reversal, I really think that we can be confident that some sort of harm has been done. And the harm is that when we deployed a treatment, which we then find out to be ineffective, is that patients have received ineffective care. At very best, there's just an opportunity cost, right? They could have gotten something else which would have been more effective. There's always a monetary cost, right? Nothing we do is cheap. And people talk so much about low value care, right? And high value care. The lowest value care is care that does nothing, right? That's ineffective or that something else could be done. And then some of these interventions actually cause physical harm. I think one that we talked a lot about at the beginning of all this was vertebroplasty for spinal compression fractures. And there were some, scary iatrogenic injuries with vertebroplasty in patients who probably shouldn't have been receiving them. After there's a reversal, de-adoption is not rapid. All sorts of estimates about how long that takes and why it happens. I'm going to show you one slide. And then what strikes me the most is loss of trust in the medical system. And I mean, we seem to sometimes work to undermine people's trust in the medical system, but reversal certainly does it. And I tell the story, and it's really still true, is that I still have patients, women who I treated, in their 50s, in the late 90s, that I was giving estrogen replacement therapy to. And these women are now in their 70s and 80s. And when I recommend a treatment, they'll say to me, Dr. Cifu, is this going to be like estrogen replacement therapy, which you put me on and then went back to me and had to take me off a couple of years later? And if that is stuck in their mind this much time while they're still seeing the same doctor, we really got to worry about how this affects people. This is a cool article that I couldn't cut this out. This sort of looks at de-adoption in a way, and I think it's just nice when you start writing about something and other people, kind of pick up the mantle and run with it. It's a mixed metaphor. So these were people who said, let's look at when there's a reversal, how specialist societies respond to that reversal. And do specialist societies say, yeah, we shouldn't be doing this, let's abandon this treatment? Or do they resist the reversal and try to keep doing what they were already doing? So they took 20 examples of medical reversal, some medications, some procedures, some screening tests, and they compared the responses in journal editorials to the responses of specialty societies. And it's pretty neat, and I mean, not at all surprising. What they find is that specialist societies were much more likely to continue to support the treatment that had been reversed, and were much more likely to actively challenge the study which brought down what they had been doing. I like to tell myself that this is not all financial. It's not that like I can't give up this procedure, which it's going to send my kids to college. But it's that you do something in medicine and you get to believe in it, and you've seen what you think is it working. And so it's hard to abandon something which you've been attached to. Why does this happen? The list in reversals is huge. The most important thing is our faith in mechanistic arguments, right? We learn stories when we go through training, and we understand why something should work, why atenolol should be a good blood pressure medication, why decreasing blood pressure should always, always, always decrease the risk of stroke or heart attack. But the reality is that treatments only work if they're shown empirically to work. And I think, many of the physicians here who've gone through training have probably, been kind of trolled down rounds and asked, why do ACE inhibitors work in heart failure? and you go through this long explanation of what you learned in pharmacology about why ACE inhibitors should work in heart failure, afterload reduction, remodeling, blah, 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 blah. And it doesn't matter. It's that they've been shown in randomized controlled trials to work for heart failure. And like, that's the answer, right? And then on top of our faith and mechanistic arguments comes all sorts of inadequate data listed here, or adequate data like good RCTs. But even RCTs are never, ever, ever perfect. And there are certainly reasons that that might mislead us. And then I threw on here evolution, because sometimes you actually have a good treatment and a good randomized controlled trial showing it works, but then over time, other things change and makes that therapy no longer effective. I don't know if that's like really reversible, because nobody's really made a mistake, but maybe it's that we've become too comfortable in the data we have and have never thought that we should look back on this. I'm just going to throw out a couple of highlights. Done talks where I've done nothing but talk about these, but that's kind of boring. And so these four are, I think, kind of my favorites, and I'll go through a few of these real quick. So subjective endpoints. When you're looking at a subjective endpoint, you have to understand that there's a placebo effect just of doing the intervention. And the placebo effect is real and powerful. And anybody who's ever, everybody, right? Anybody who's ever had their bruised knee kissed by a parent, like, understands the placebo effect, right? But it goes to being a patient, it goes to being a doctor, and it's an important part of what we do. I always think if you're not using the placebo effect as a physician, you're not a true physician. That's like part of how you practice. You have to. But if you're studying something and you're studying something that has a subjective endpoint, your control intervention needs to be as similar to the experimental intervention as possible. And for surgery and devices, this always, always, always means sham controls. These are some kind of highlights over the years of just things that we had done. We thought that they worked until we had a really robust study that overturned things. And these are just coming out all the time. JAMA seems to be obsessed with platelet-rich plasma these days and is like putting out an article every 3 or 4 months about platelet-rich plasma for knee OA, for Achilles tendonitis, for plantar fasciitis. The first one here, internal mammary ligation, I learned about in medical school. This was this idea that if you went in and tied off the internal mammary, I think now called internal thoracic arteries, that the blood would back up and perfuse your coronaries and your angina would go away. And people were doing that, getting that done, until a really good sham surgery was done where people were left with the scars of their internal mammary artery ligation, and it turned out to be completely ineffective. These are a couple of good descriptors. This is a guy I was an intern with, published this study in the New England Journal. And it was pretty neat for a couple of reasons. He randomized people with asthma to either albuterol or a whole bunch of placebos, either a placebo inhaler, sham acupuncture, like not even real acupuncture, sham acupuncture, or just no intervention control. And if you're measuring people's airflow, their forced expiratory volume, not surprisingly, albuterol is better than all of these controls. But if you're not looking at FEV1 and you're just asking people, how do you feel? It turns out that placebo and sham acupuncture is as good as albuterol to make people feel better. And so, we're talking about like breathing, like that's as core to survival as possible. And a placebo can make you feel better. And then this trial I found amazing. This has nothing to do with what I do as a doctor. This is cortical stimulation to control seizures. So this is a device which basically says, oh, this person's about to have a seizure. And it almost, I think of it as a pacemaker, paces the brain to try to override the coming seizure. And you have to recognize, like, these are the most difficult to treat seizure patients, right? Truly medically intractable seizures. And these authors did an amazing job where they implanted this device in about 200 patients, but they only turned it on in about half the patients. And what the data shows you is that on the one hand, this is actually kind of a cool treatment, right? These are people who are nearly impossible to treat, and they decreased their seizures by about 40%. But what's cool is that a sham intervention, just putting this in and not turning it on, actually decreases these people's seizures by about 20%. And like any good placebo, it works, moderately, and then its benefit sort of fades over time, just as you expect a placebo to work. Surrogate endpoints, I get totally hung up on surrogate endpoints. We have to use surrogate endpoints in clinical trials. Clinical endpoints they're difficult, they're expensive, you need lots of people for a long period of time, and surrogate endpoints allow faster, less expensive studies. And we really believe in surrogate endpoints, but even our most predictive endpoints have led us astray. This is sort of a list of some of the really famous ones over time where we've failed because a treatment maybe suppresses PVCs, which are good stand-in for sudden cardiac death, but actually they increase the risk of death even though they're decreasing the PVCs. And hospitalization, which was a cool study. I think we use hospitalization a lot as a surrogate endpoint because people tend to get hospitalized a lot more often than they die, and we think that hospitalization is bad and maybe a step on the way to death, so let's use that. And these authors took a bunch of trials which reported both admission rates and mortality rates. And what they found is that almost a third of the time, interventions which increased or decreased hospitalization, decreased or increased death. So you might have something which was actually decreasing hospitalization, but increasing mortality or vice versa. And it was pretty strong, about 8%, let's say 10% of the interventions had opposite effects on hospitalization and death with no overlap in the confidence intervals. And there was no correlation between the effect sizes for admission and death. So I thought the sort of moral of this is, it's important to prevent hospitalizations. It's important to prevent death. They're both important outcomes, but you should never use hospitalization as a stand-in for mortality because it might very well be that decreasing hospitalization actually increases mortality in the patients. And then the last two, is probably the most recent thing we've written about. It's reversal by evolution. And I kind of love this. That the idea that medicine changes so much over time, that something which is really beneficial at one point might not be at another point. The thing which has maybe been the splashiest lately is prophylactic aspirin therapy. That's kind of fallen out of favor since the time that came into common use. People have gotten healthier, right? We use statins. We don't need a lot of trans fat. We exercise more. We smoke less. And so therefore aspirin has less of a beneficial effect while the harms have stayed about the same. And so that risk benefit ratio has now kind of gone more on the harm side than the benefit side. There are also good examples of where we have an effective medication, but then other treatments get so much more effective that effective medication just has no effect in the overall scheme of things. For me, I think of ACE inhibitors, angiotensin-converting enzyme inhibitors in patients with vascular disease. There was a few years in the early 2000s where we had really strong data. I think it was the HOPE trial that showed that taking someone who had vascular disease and putting them on an ACE inhibitor decreased their mortality by 2%. That's as good as beta blockers post-MI. That's huge. But then studied a few years later, when all these people with vascular disease were on statins, it turned out that adding ACE inhibitors did absolutely nothing. And then the last one, and this is maybe sort of speaks the best for medicine, is that you can imagine screening for something, and that screening is important because it picks things up early when they can be treated. Well, you know what? If our treatment gets really good and you don't need to pick things up early anymore, then it doesn't matter if you screen. Testicular cancer screening is probably a good example of that. I put it in italics because there was never data for testicular cancer screening. But like now, right? I mean, oncologists know this better than me. You can wait until someone has metastatic disease and still cure them. So screening is no longer important. And as you think about a lot of the diseases that we screen for, it'll be interesting over time. Do we still need to do that as we get better at treating breast cancer, lung cancer? We'll see. And then the last one, post-randomization confounding, which is kind of a neat thing, right? We do randomized controlled trials because in doing a randomized controlled trial, we end up with patient groups that are identical other than the intervention that we've chosen. In post-randomization confounding, what happens is that after that randomization, something happens which creeps in to make those two groups different again. And it might be that they get different medications, they get different rates of disease screening because one group is going to the doctor more than other. There might be differential loss to follow-up given the effects of the medication they're getting. And this mostly happens in long-term or sort of pragmatic trials. One of the other things I've always been obsessed with is estrogen replacement, as you already heard. And this is kind of neat data, which I don't think kind of undermines the Women's Health Initiative that comes out of the Women's Health Initiative. As a reminder, the Women's Health Initiative showed us that just prophylactic estrogen replacement therapy in postmenopausal women is not something we should do routinely. It actually increases the risk of coronary heart disease and stroke. But the Women's Health Initiative was done in the mid-90s and early 2000s, a time that we were just starting to put people on statins. And at the time, you prescribed statins not because of ASCVD or cardiovascular risk, but because of LDL levels. And interestingly enough, estrogen replacement therapy, we were using it because we thought it helped for heart disease because it lowered LDL levels, okay? And so what happened in the Women's Health Initiative is actually that people who were randomized to placebo ended up getting put on statins more than those people in the estrogen replacement therapy group because they had higher LDL levels, okay? And so maybe it wasn't that the estrogen replacement therapy was making things worse for people. Maybe it was that the statins in the placebo group was making things better for people. And this is just graphically the difference in statin use over the course of the Women's Health Initiative. And statins are pretty powerful. It may not have flipped these results, but this lower confidence interval on both of these were pretty small. And you can imagine that the effects of statins maybe wiped out that clinical significance. So summary, reversal occurs when an accepted practice is overturned, happens for a bunch of reasons. We have no idea how common it is, but it's at least some percentage of what we're all doing, which doesn't have a great evidence base, is sort of open to reversal. And there are certainly harms. What we can do about this, as I go on in my career, I lose hope that we can do anything about it. But there are probably things that we can all think about, where can we intervene on that? I sort of spend my time trying to, brainwash my students on thinking really hard about the practices that they're adopting. So let me, before breaking for questions, let me kind of go into COVID. And as I said, this is going to be a lot more soft. And I hesitate to do this because about a year ago, someone gave grand rounds here and he said, I'm not going to talk about the thing you expect me to talk about, something I know, but I'm going to talk to you guys about the things that I think about on the way to work in the morning. And I was like, I want to hear what you think about on the way to work. That's not why I'm sitting here, but I think maybe that's what I'm about to do. So just like a reminder, so EBM, evidence-based medicine, that's what we all do, or at least we all think we do. That's practicing medicine based on an understanding of biomedical science, clinical experience, and the best data from systematic research. People always describe this as a three-legged stool, that our practice is only stable if it's supported by these three legs. And if one of those legs, I don't know, breaks, becomes loose, isn't there at all, your practice is going to be very unreliable as your three-legged stool would be with two legs. Medical reversal, we just talked about, and COVID is, right, COVID. And so what I've kind of seen over the last couple of years as just being, a general internist, both inpatient and outpatient, is it's really clear that it's a whole lot easier to counsel data when your recommendations are based on robust data. When you start explaining why people should do something and it's just based on science, it was often not based on clinical experience because we didn't have a whole lot of clinical experience. Patients tend to ask you good questions, which you're often not really able to answer. COVID also really challenged the idea, that all practices can be data-driven, right? We practiced for the first few months of COVID basically with no data at all, at least no good data. And then there's some things which are just so hard to study. That, it's made me accept that, boy, there are some things that third leg has to be pretty weak. And then I think the last one, I had trouble figuring out how to say this well. But when we're treating people based on biomedical science, clinical experience, and really iffy data, what we're left saying to patients is like, I think you should do this. And I think you should do this because it makes sense. But because I don't have data, it's almost impossible for me to outline risks and benefits to you. And so then what often happens is that the patients are making decisions based really totally on the values that they're bringing into the clinical encounter. And so our role almost becomes less because we always say, look, we went to medical school, we know the medicine, and that's what we're going to tell you, but you're going to make the decisions based on values. And so I think what's happened in a lot of this, whatever decision it is, whether it's, masking or, vaccinating the lowest risk people, or, how aggressively you isolate, comes down to being based more on values than science. There are always times that you practice without robust data. And Vinay, I'm pretty sure it was you who kind of, came up with these things, which are so true, right? So like early experiments, phase 1 trials, we recognize, of course we're doing that without data. That's just part of, figuring out how to practice. That's research. Situations that happen rarely in medicine, right? Things that we could just never do a good clinical trial on. Dire circumstances. When I was a resident, people always used to say, nobody should die without a course of steroids, right? If someone's doing terribly and you've no idea what the hell's going on with them, you're just like, just give them some Solumedrol and see if they get better. And then complex management. So there are a lot of patients, medicine is so complicated and so many things might go wrong that you'll have patients with a mix of problems that you've just never seen before. That's kind of like the number 2 up here. And those times you're always going to practice without robust data. And a little bit what's frustrating in COVID is that COVID has sort of started as a rare, dire situation. And then at some point over the last couple of years, it certainly wasn't rare and it has become less and less dire. And so it goes from being something where you kind of should have been allowed and you were okay to do whatever the hell seemed reasonable to a time that, maybe we owe it to our patients to be practicing in a more evidence-based way. It's really neat that if you sort of look at debate now, you can really say that like, there is no debate where we have robust data, right? I mean, there are crazy people out there who are going to debate these things forever. But for the most part, like we don't talk about vaccines. We don't talk about the use of DEX in the hospital. We don't talk about, or like, reasonable people don't talk about using hydroxychloroquine or ivermectin or convalescent plasma. And even where the effect size is really small, like remdesivir, monoclonal antibodies, Paxlovid in the unvaccinated, we don't even argue those because we at least have the idea of like, look, this is how much it's going to help. But where our data is weak, people still yell at each other, should we mask? when we're at the grocery store? Should we use Paxlovid in people who are vaccinated, who, to be honest with you, are like the only people who I'm using Paxlovid in, which I know is crazy, but we argue about it. And then, please don't get mad at me, but there is argument about like the lowest risk patients. Most of us would say, whatever, vaccinate everybody, but you can argue about that reasonably. This is a Tribune op-ed I published just last month. And I kind of tried to say, how can we talk to each other and try to figure out why we disagree. And there are a bunch of people who've tried to do this in the past and say how do we align? Jerome Groopman tried to say, when we think about medical care, some of us are minimalists, some of us are maximalists, some of us are believers, some of us are doubters. Eric Oliver, who's a political scientist here, who I think is really, a bright guy. He sort of said our big divide is not like liberals and conservatives, but it's rationalists and intuitionists. And he came up with this whole, a bunch of tests and questions to actually see, are you more of a rationalist or are you more of an intuitionist? And that tends to actually track with how open you are to conspiracy theories and things like that. And I sort of said, when you talk to people, you can disagree with people who are really well-meaning, who have the same data that you have, but are more of an optimist or more of a pessimist when you're the opposite. And optimists are people who are COVID, it's kind of a bad cold these days, a bad cold in the people who get it the worst. And they sort of look ahead and they say, we're just going to have smaller and smaller, less severe waves. And it's just going to be like any coronavirus, that our immunity is not perfect, but it's going to do well enough. And whatever, we've all got sick. And also they're a little bit maybe fatalistic about the whole thing and say that, look, we're all kind of wimps. We haven't had to worry about infectious disease because we've been vaccinated for everything since the early 60s. But now we just have to live again with, unavoidable infectious disease. The pessimists are sort of this is a bad thing. And every time it mutates, we can get it again and it's becoming more and more transmissible. And we should be concerned. And the pessimists are kind of more concerned with long COVID. Even the pessimists don't believe that 20% of people are going to have long COVID like the CDC is trying to tell us. But at least they're saying, this is more than just a prolonged phase of recovery. Maybe this is something new and real. And so therefore, we should really continue to employ all of our tools in everyone to suppress the activity and evolution of the virus. And you can see as someone who's way on the optimist side of the spectrum and way on the pessimist side of the spectrum, they're going to disagree even if they share actual knowledge in the middle. And maybe my final plea that for the people who actually do work, unlike me, we really have to try to get as much data as possible, even at this late stage, to prepare us for the future. And I think convalescent plasma is an amazing kind of story, because I think we leave COVID hopefully agreeing that, convalescent plasma doesn't really work very well. We went into COVID at a time that we should have known that already, but we had kind of wasted so much time for 100 years that we didn't have that information. COVID's been used, convalescent plasmas was used a ton for the 1918 flu pandemic. Used enough and actually quote unquote studied enough that these people from Annals in 2006 were able to do a meta-analysis to sort of look at it. And the studies were all terrible, right? It was 1918, everybody was dying. They were mostly just doing kind of case series or observational studies. But what they did find in this meta-analysis was that, well, maybe there was a difference, and it looked like a pretty big difference in mortality. But that was 1918, right? So we had 101 years to come up with better data, and we didn't. There are some great kind of medical history stories. convalescent plasma used in a measles outbreak in 1934. And I just love this, that someone actually asked the treating physician, like, well, wouldn't it have been good to have done the trial? And he said that we feel on the basis of past experience that the subsidence of this outbreak was due to the use of convalescent serum. It was like, I'm not testing, I'm sure it works. And then what was most annoying to me is that there were actually 7 publications in really good journals of using convalescent plasma for Ebola, SARS, ARDS, and influenza in the last 20 years. And none of those were trials. So when COVID came around, we were just at a loss. And we're like, if we don't use it, maybe we're underutilizing an effective therapy while our hospitals are filling up. Maybe if we use it, we're using a dangerous therapy. We actually know that there are real adverse effects with convalescent plasma. Or maybe we're like just wasting a ton of research and resources on a totally ineffective therapy where we're having people come in and give plasma, we're having people come in and get plasma, and it's not helping. This is just, I was worried that this was just going to happen all over again. This is March 27th, 2020. Ridiculous case series out of China that tried to tell us again that convalescent plasma was working. And where are we? We use convalescent plasma in probably 94,000 Americans in the first, 5 months of the pandemic. The trials which have been done, and there are a good number of trials, show that it really doesn't seem to work. Though people always point out, well, it may be possible if you use exactly the right serum from the right person at the right time in the right patient, that might be true, but that's just not a possible way to practice medicine. And so as we, I like to think, leave this pandemic, I think we should be thinking about the things that we're still uncertain about, the things we're arguing about, and kind of figure out, is there still a way to study those so we'll be sort of prepared for the next time. That's all I have to say. So sorry, actually that was 50 minutes, that's okay. Thanks. So just totally opening up, what do you guys think? Where are you in the COVID disaster?
That was brilliant. I think I'm sure they're going to have many, many questions for you. I guess I'll just, while everyone's thinking, and you can either, if you feel comfortable asking, you can ask. You can also put in the chat and I'll ask. But I thought it was just brilliant, and especially the way you combine things at the end. And I wonder if you might talk a little bit more about another thing I think about, which is, one of the things I thought was particularly brilliant is your point that, when evidence is clear, there's no argument. I never talk about DEX because we have recovery, and I never talk about these things that were proven. But the things we argue bitterly on is, as you say, I just met a bunch of people my age and they're on Paxlovid for their, scratchy throat. And you're like, well, of course, Epic HR has it for those people. That's the debate. Masking 2-year-olds. Of course, it's going to be debated because, it's a 2-year-old and it's a cloth, of course he didn't do it. Okay. Yeah. So I guess, but the question I wanted to say was, you dichotomize it as like optimists and pessimists. And I certainly think that's one axis, like how do you interpret the threat? And then I wonder if you might talk a little bit about another axis, which is optimism and pessimism about human beings' ability to control the natural world. Because the more you do reversal, the more I feel, powerless and impotent in the universe of nature, and that kind of thing. Where do you fall on that spectrum? How does it play in?
Yeah, so it's funny. I had a paragraph in that op-ed that I had to cut out because it was kind of confusing, because in a way, my pessimists, I think, are in a way more optimistic about human behavior. They sort of feel like, if I tell everybody to continue to wear N95s whenever they have human contact, people are going to do that. And that's going to, lessen the risk of COVID. While my experience with kind of the optimists are like, and if we try to do things like that, nothing's going to work and it doesn't matter anyway. And that's why they're sort of more fatalistic, right? which is why I think this optimism, pessimism breakdown are not the words, or maybe it's just that people are a whole lot more complex than we think. And it really is a spectrum, and nobody's perfect on either side.
No,
I'm at a point where I sort of worry about making those recommendations, that it's just going to make people hate, the NIH, the CDC, and medicine in general more.
well, I mean, I don't know. I think you're onto something. I certainly feel like that spectrum does exist. And I think there is a spectrum of like, how powerful are people to control the world? And then I think there are always the unintended consequences. And, the thing about doing this kind of work that you and I have done for so long is we have seen so many super smart people were like, well, I got you the answer. People are coding on the floor. So what's the answer? We'll have a rapid response team. If the nurse is worried at all, they'll dial this number. The team will shoot in. They're going to check the vitals. They'll bring oxygen. And guess what? We're going to transfer them to the ICU. We're going to transfer them early, and they're not going to code in the hospital. That's how great we are. We're powerful. And then they did it in a cluster randomized trial, Merit in Australia, and not a single change in death. They died in a different place. The old quote, "Hope springs eternal." Blessed.
And we've made mistakes in this. There was a Twitter conversation last week, which I thought was great. When I reflect on the whole thing, I was buying into, spring 2021, like, we've almost got our vaccination rates up to 70%, herd immunity, we're going to be perfect. Yeah. And when I think back on that, I was like, what the hell was I thinking? That was idiocy, because this is coronavirus. This is a coronavirus. This is going to continue to change. It's going to continue to mutate. We're going to get this forever. And the vaccinations or exposure, what they do is they keep us from dying from it. And it's not going to be like measles or smallpox or something like that, where we can come up with one vaccine once and we're going to be done. And it's also not going to be, we're going to come up with, yearly vaccines, because we don't vaccinate against the common cold because we don't care. Right.
And I think that the vaccine people, there was a reason why they didn't pursue it for so many years. They know about immune evasion. But it's funny, the pessimists do tell me, that the next one's going to stop it for good. So that's why you got to hang on a little longer with that N95. Okay, Christina's got a question for you.
Yeah, I guess, so thank you again. Thank you again for this presentation. And I have your and Vinay's book, so I'm definitely a believer, but I kind of wonder.
That's why we're rich. That's why we're rich.
I guess I kind of wonder about the solutions, because there's so much literature that's published every day. I used to be a registered nurse. There's no way that I could keep up with it. Yeah. Sometimes when I speak to some of my clinician friends, they just immediately back away, especially some of my family doc friends who are just overwhelmed with the system right now. And they're just like, there's no possible way we can keep up with all this literature that's published. Like, what, I guess, do you suggest for, what do you suggest for clinicians to be able to sort of keep on top of this stuff?
No, it's a great point. And there are times that I'm actually really pessimistic too, because I really do think it's gotten, in my career, it's gotten much harder to read the literature and pick out the problems, because the people who are trying to sell us therapies have just gotten so much more advanced, in how they get things through. But I think the reality is that anyone, and I won't say just physician, because it's really any one healthcare worker, isn't prescribing 3,000 different things, right? My clinic is very broad, but there are probably, 25 drugs that I'm using 90% of the time. And so I think it falls to each physician to say, look, on the little swath of medicine that you're in control of, you got to make sure that those things all work, right? And if you don't have good evidence that they work, you may still use them, but when you counsel patients, you should admit that, because then, as I said, it comes to be a value discussion. And I probably do more, I don't want it to sound like self-important, because I'm a general internist, nobody respects me, but I probably actually do more than a general surgeon or a neurosurgeon who's doing spine and is doing, 4 operations and making 10 times as much money as I am. So it's probably actually easier for them to figure out if what they're doing is actually right.
Adam, and then I'm going to go to a question for Logan, but first just follow up. And what's your practice? How do you keep up? What do you do? What's your routine?
I have a handout. So I don't know, the pitch I have is that, like, I read a lot, but the only things that I read really, really carefully are the things that are going to change my practice like tomorrow. And so, I have all the table of contents for all the main general medical journals emailed to me, but I skim those and I'm like, I want a positive randomized controlled trial that's going to change my practice. And you know what? There are a lot of weeks that go by. I don't actually have to really read in detail any of those articles. There are other things I'm interested in that I skim and I tweet about, but the things that are good, it's a few a month that I really have to get into. And everybody's different. So I'm like, as general as you can get. My wife is an academic pediatric dermatologist. And it's funny, like I skim 6 journals, right? She sits down and she reads one cover to cover. I'm like, what the hell are you doing? And she's like, well, I have to know this stuff because I'm absolutely, the last line for these kids. And it's interesting. And it's like, I'm a fox, she's a hedgehog. It's why we do different things. And it is sort of, it really bears on what you're doing. You have to say, like, what's important to me? Am I going for clinical excellence or clinical adequacy? What's my practice pattern? Who am I treating? And that all bears on how you read, I think.
Logan, let's do your question.
So I have a couple, but I'm going to go with this one, which is, you have all these strong talking points and amazing examples, both in this talk and your book. But my question is how to apply these questions, because say you're in grand rounds and you come off very nice, but some of us don't. Like I can come off very brash. And there's a question you have in the grand round presentation that you really disagree with. How do you deliver these talking points without the risk of offending a colleague or just probing them a little bit? What about your delivery, I guess, is my question.
Yeah. I wish I could answer that well, because I don't think there's ever been a grand rounds that I've been to, right? And I can go, whether it's Cologuard or using virtual reality for pain control, where like I listen to it and you're just like, this hasn't been tested for one of the reasons on that slide, right? And right, I could be the most hated person in the world because I could basically raise my hand and ask the exact same question at every grand rounds. So what I usually do is the old compliment, like, oh my God, this is incredible. This is such an exciting place that you're working on. It seems like the one thing we're missing here is this. And I try to make, this sound unimportant, where in fact it's, I think, the only important thing. And I have to say that most people acknowledge that and say, yeah, we could really use this, right? And I kind of hope, well, maybe that stimulates them to do the work. Maybe at least signals to the other person in the audience that, we are really missing a key piece here. And if people really hunker down about it, then I tweet about it. I go behind their back. But I think that's at least a way of doing it. And, we're dealing with smart people. And for the most part, people have actually really thought about what they could do to make their research better. But the fact is that doing the research better is hard. And doing it with a clinical endpoint, doing it with better outcomes, having it go on for longer, having more robust controls are all things which cost more, take longer, and they'll admit that,
I'm sorry, I need to tack onto this question, but it's in line with what you're answering, which is, and Vinay, I think I've heard you say this too, is that sometimes the goal shouldn't be to convince the individual on the stage, but more so the readers of the literature. So do you sometimes hold back on a question and then write a piece on it?
I think Vinay does a great job with this because he seems to churn out an article every 3 or 4 hours. When I am less effective at that. And, when I write those sort of, opinion thought pieces, they're sort of 3 or 4 a year for me. And so I do that less for individual points, but I do it when it's like, I feel like this is a trend, and let me throw this out here so people can consider this when they look at research in general. And maybe that's for someone who's just not as productive or doesn't take as much amphetamine, might do it.
No,
Perfect,
but I
thank
think
you.
you're being a little modest, because I think you, and I want to say that the question is very good, because the question is, when you're in this situation, the grand round speaker blabbed on about some unproven screening test, and your point is, there's no randomized data that shows that works, and that's what it's going to take for me to change my practice. That's what you want to say. You can try to make the point in the grand rounds, and I think there's probably few people who could do it better than Adam, because I think he knows how to put it as well as you could put it. My own personality is, I know I can't put it well, so I don't even try. They're going to think I'm an asshole if I tried. But then my mind immediately goes to how can I persuade the audience? And then I think, well, you could try to write a commentary or try to do a plenary session or make a video. And I think Adam does it too, because all his lectures to the medical students, he has imbibed the things that annoy him, and then he makes those points really well to the students. And so he's changing a whole generation, taking that energy and putting it in that direction. And so that's why I think you're a little modest, because you're probably very effective at that. Sunny has a follow-up question, and then Emma has a question. Let's go, Sunny.
Yes, thank you. I've been a follower of your Twitter account for many years, and thanks for the great talk today. So you mentioned earlier that physicians often fall on a spectrum of optimism or pessimism about how effective they can change or affect nature. And I do think patients also fall on some type of spectrum also, which is what their values mean. And so I feel that it's much easier to talk to patients that fall on a similar point of spectrum. But do you think for the patient, it's better if they have a physician that shares very similar values, or to see the other point of view, it's better to have a discordant value?
Yeah. Wow, that's a great question. It's funny because I think of it so much on the physician's side, right? And maybe this answers it, because I recognize, right, the patients who I agree with, I'm sort of at their set point, and those who don't. And I think my task is kind of different with those people, right? So the people who are real, diagnostic and therapeutic minimalists, who are sort of like me, and I'm thinking of someone right now, right? I feel like my job with him is to sometimes pull him a little bit in the other direction, right? Let's make sure that the two of us are going to get in a room and we're just going to decide to never do anything. And often when he decides not to go forward with a workup, I'll present it to a colleague and I'll say, I got this guy, this is the issue, we've decided not to do anything. Is that crazy? To sort of check myself. On the maximalist side, those people, to me, we often have a discussion where it's, I need this. Okay, let's just say I've had 4 vaccines. I tested myself for COVID because I was going to a friend's house and she said I needed a test and it's positive. And I want, can you put in Paxlovid for me? Okay. And my thinking is well, that's ridiculous, but the person saying I need it, right? Because they're maximalist. And so mostly what I say to those people is I'm like, listen, it's not really approved for this way, and we don't really have any data for it. And even in the people who would respond to it much better than you, this is it. And these are the adverse effects you're probably going to get. So, I wouldn't do it. Listen, I'm willing to write it for you because it's not harmful. And so I sort of try to draw them a little bit to the middle. And so I think maybe the best thing is, this is going to seem really self-important, is not to find a doctor who aligns with yourself, but a doctor who's sort of, going to try to practice correct medicine, and is okay talking you to it, depending on where you come from?
That's such a great answer, and Adam. I think maybe, and Sunny might feel like this a little bit, because I know Sunny for many years, and so I have a sense of her. But Sunny and I are both in oncology, and I often feel like the more common scenario in oncology is that second scenario you talk about, that the patient is a maximalist and we're the oncologist, and we know a lot about the limitations and side effects of our therapies. And so you often have somebody, I want the new shiny thing, and it's better, and it's earlier, and give it earlier, and treatment when you don't need to otherwise be on observation. And it's a lot of, exactly as you say, trying to say, I think I'm very close to your philosophy, which is like, at the end of the day, if you tell me you want this, we're going to do it. But I just want to let you know, here are the things that weigh in my mind as to why I would have a little pause. But I think it can be tough.
I think it's such a cool question. I might reach out to you to write something about it, because, there's a lot of information coming out about, seeing, race concordant or discordant doctors, gender concordant or discordant doctors. And some of that is kind of convincing. I find the race concordance most interesting, because there's sort of information both from the patient side, and there was a New England Journal editorial about a year ago looking at patient evaluations of doctors, and the bias in those. This was sort of black-white, and it was shocking, and it would be interesting. Though I think most, the patient feedback we get is just garbage. But it would be interesting to see, like, if you could identify, minimalists and maximalists in your practice, and you could put yourself on a spectrum and see, like, who gives you better ratings. That actually kind of be a cool thing. And maybe, like, for my Press Ganey things, when people would come to me, I would ask, like, if you're a maximalist, I don't want to see you, because you're going to give me a shitty grade, and my 5-star or 4.9 or whatever rating I am on the U of C site's going to go down.
Such an interesting point. Emma Greenstreet, I didn't introduce you to her because maybe she just joined. She has a question, and as introduction, she's a medical student here at UCSF and is quite brilliant, worked on a paper with me on podcast. Emma, go ahead, ask your question.
Hi, yeah. Hi, I used to live in Hyde Park, so I kind of...
So we've probably seen each other on the street at some point.
Yeah. I just completed my internal medicine rotation, and so, like, after listening to your talk, I'm just a little bit curious whether, I know you gave already some examples, but whether there was anything that you're skeptical about now or think that might be reversed in the future in terms of internal medicine practice.
Yeah.
That
Nothing I
you just wrote, that Paxlovid you just wrote for that healthy 40-year-old person, right? Yeah.
Nothing I do in my practice is going to be reversed. The things that I've thought about, actually, because I've been thinking about this whole evolution thing, is things that we have accepted as practices, which I think honestly may not last. And I'm really interested in lung cancer screening, right? Which is something which I think, has barely made it over the hurdle to becoming accepted practice, mostly because, as a diagnostic test, it's not so great with the number of false positives. And I think that, treatment for lung cancer now is something which is like unimaginably good compared to what it was a decade ago. And I kind of think that if you reran those trials now, I think you actually may not have a benefit, because we'd be able to treat some of those people well who get diagnosed a little bit late. I bet also screening for, this is like picking on smokers, I bet screening for AAAs, I really wonder, as smoking rates decline, smoking intensity declines, statin use increases, for people with high ASCVD who are, smokers are by definition, I bet that intervention is going to fall, especially because that's a much more morbid therapy. So those are a couple of things I'm thinking about.
Oh, those are so great. And I totally agree with you on CT screening lung cancer. One trial, the control arm, chest radiography, not the standard of care. The overall mortality benefit vanished in the subsequent paper by Pinsky. And the other trials got more protocol amendments than it's as redacted as the Mueller report. I mean, I've not seen anything like that. It's all blacked out. What the hell happened? One more question, and maybe we have time for maybe two more questions. This is from John Markart. I didn't introduce him, JP Markart. He's surgery resident in Medical College, Wisconsin, MCW, and worked on a few projects with me. And John, go ahead. JP, give your question.
Hi, Dr. Cifu. Thanks for the presentation. It was really great. I just wanted to ask kind of one of the things I run into, and I'm going into pediatric surgery, so and I'm doing my research years, but I still take clinical call. One of the things I see a lot is even as we start to gain evidence for practices, it's also not really disseminated to patients in a lot of ways, and then they have very strong opinions, as you probably have run into at times. And one is like appendicitis is like the most common thing I see, and obviously we now have some data that our center was even a part of for randomizing patients to getting just medical management versus surgical management. And I present to patients, all the data that at a year it's 70% successful, 2 years out it's about 6% successful. You get avoided surgery. Still, the overwhelming majority, vast majority, push for surgery because obviously they've always been told if it was heard, it's this like thing in the culture that you should get your appendix out if you have appendicitis. And I guess I'm wondering, kind of, is that something that you think affects the duration of time to change to have a medical reversal, and how do you often deal with that with your patients?
Maybe it depends more on if the physician is salaried and or is like, pay for procedure kind of thing.
Yeah, I'm a resident. I get paid a flat fee all the time.
And a low flat fee at that. I think that's an amazing question because, I think we leave patients out of, medical decisions. In our analysis of medical decisions, we leave patients out a lot. And that's probably something that we should be more sensitive to because, I bet if I just consider my own practice, right, it's probably a couple of times a week that I go into the room thinking that one thing's going to happen and something else happens. And that's because of the patient desires. And I think that where it becomes most important is probably in things like appendicitis, right? Because there are always going to be people who we treat appendicitis or diverticulitis with antibiotics who then go on to need surgery, say, right? And the benefit of medical treatment in that group is you just decrease the numbers. And so there's always going to be an argument for a patient to say, well, I just want it over with. And so I think it'll get to how strong the patient feels about that, how strong the doctor feels about it, what sort of an argument they can make. And that's going to vary by physician to physician so much. And I know I'm kind of rambling, but as we think about whenever there's variability in physician practice, in the past, we've thought that was a marker of something wrong. But maybe it's not. Maybe this just comes down to it's more of a, who listens to the values of their patients more or less. I don't know. You guys ask great questions. Things to ponder. It was interesting. Yeah, I was just going to say, I gave grand rounds to the surgeons here about a year ago. And I did my damnedest to say, I'm not going to talk about medical reversals. I'm going to talk about surgical reversals, and had to come up with all these slides for that.
Gentamicin sponge or something. Yeah.
And man, the surgeons overwhelmed me when I finished about all the things that they were pointing out about that, either they knew that there was data that was undermining what they were doing, or they were doing something that they were like, I don't think what I'm doing is well-founded. And so I think if this is something, you got a great start with appendicitis, but boy, probably the numbers of things you could pick off, boy, especially in pediatrics where we study like nothing, right?
he got a great paper I'll tell you about offline, but yeah, I think it's ripe for that.
Yeah.
Timothy Olivier has a question.
Yes, thank you again, Dr. Cifu, for the really great talk. I have a question about the de-adoption process that seems to be difficult, and I wonder if the most difficult thing is having a doctor to change his mind. And we know in social psychology that it's very difficult. I mean, for everybody, it's very difficult to change your mind on the way.
Yeah.
And do we think about some strategy where another physician or maybe another team could kind of reassess the first decision, but in a very constructive way? Maybe is it something studied, or what do you think about that? Maybe it's not a good idea, but I think sometimes it's difficult to reassess your own decision just by psychological processes. Yeah.
And as I alluded to, I think there's the forces working against changing, right? None of us want to change. And then in this setting, it's, I've done meniscectomy on 100 people with degenerative meniscal tears, and they all got better. That's working for you. And I got promoted based on this, and I've written an article on this, and I make a lot of money on this. Like, everything is working to make you think that what you're doing is right. And so I don't think that reading a well-done sham surgery trial is going to make you, shift your entire career, right? But maybe what we have to focus on is, the people who do those trials then saying, look, you need to go to the cardiology meetings, you got to go to the orthopedic meetings, you got to talk about why you found what you found, and what should be the new direction, so you kind of replace where people failed. I think Vinay and I both know a bunch of people who've done these sham kind of trials, and they have a tough life. I wouldn't say they become pariahs, at least not as much as Vinay.
Yeah, I was going to say.
They often just get worn out with making their arguments.
Related to that, you're a good internist. Maybe there's a role for you're not going to send your patient for the spine surgeon unless you already kind of probe that. You're not going to send the patient for a stent unless you already kind of, right? You're not the person putting in the stent. You're not invested.
Right. Yeah.
Nora has a quick question, and then we'll do some closing remarks. Okay, Nora, you're up.
Yeah, thank you. Thank you, Dr. Cifu and Dr. Prasad, for inviting me. I'm a basic sciences researcher. And so one question I have that kept coming up during the talk is, when you're reading about a trial or hearing about a trial, what's sort of like a number one red flag that after you come across it, you're like, oh, this is definitely going to be reversed. This isn't going to really work. Is there something that is sort of a pattern or maybe a trend where you see, if I see this in a design in a study, I know it's going to be super flawed?
Yeah. So it's funny. You saw those two slides I had of causes, okay? And the first slide, which are mostly, things like observational trials and things, I don't even read those trials. Like, if I read those trials, I'm reading those trials because, this is interesting. But I do not read it because it's going to have any impact on my practice, because I think those are such, as far as practice changing, so low quality. I almost don't want that noise, And so the studies that I'm actually reading, are kind of well done RCTs. So I'm saying, it's a positive RCT with a magnitude of benefit large enough that I think it's, worth whatever the downside is. They're always going to be, multi-institutional, large trials. I'd love it if there was other information from before. And so those are the things I'm reading carefully. And so then the one thing which kind of sticks with me is, even when I'm sold on a new treatment, say, I'm always remembering that there's publication bias, right? So what's actually out there is all biased towards an effect. And then there's that whole thing, which Ioannidis did, brilliantly in that article from whatever, 20 years ago about why most of the literature is wrong, is just kind of working through, the alpha error, the beta error, your sort of pre-test probability that a study is going to be positive. And really, if it's a surprise and you're like, wow, I can't believe this is right. I would have said there's only a 10% chance this is going to work. That even a really perfectly well done randomized controlled trial, your post-test probability that this works is only like 65%, right? So you have to be open that even if okay, I'm sold on this, I'm making the change, that it's still not definite, right? Until you see, a bunch of things go out, or, you have clinical experience, you're like, wow, my patients are really doing better with this. That's not worth nothing, right? I mean, that does mean something.
Well, I want to give you some time for closing remarks, and I just had a few thoughts to wrap it up. One, I thought your talk is brilliant, and I don't know, I think I've heard you give the talk before. I've heard myself give my version of the talk, but it's always nice. It's like listening to a song when different people play it, it's nice. It's nice to hear. And you think about things a little bit differently than I do. And I really appreciate that. So I thought it was brilliant. And then the second part was really the part that I'm still thinking about. And I think we're going to be thinking about for many years, which is what are the parallels? And I think there's a few things that reversal reminded me of. One, there's certainly situations in medicine where we have to make choices and we don't have perfect evidence. But insofar as possible, medicine is quick to label things as that when we do have opportunities to develop better evidence. Your convalescent plasma story was perfect. So many opportunities to develop better evidence, and we chose not to do that. Often we do that because we're true believers. We think that we can make the world a better place by snapping our fingers, or whatever we do is wonderful. Sometimes we have perverse financial conflicts of interest. And then I think the same arguments like why we didn't generate the evidence because, it would be silly to, it's unethical to, demonizing people who bring that up. And I think back about the pandemic, and, I certainly think, and I was actually very quiet the first 3-4 months because it was clearly an unprecedented threat. And I think it's entirely reasonable for people to respond in unprecedented ways. But I was a little bit worried early on in the summer because I knew that, I knew the literature on the cloth mask was terrible because I had read the Cochrane review, et cetera, prior. And I knew they wanted to do it, and I thought that was reasonable. But when we didn't run cluster randomized trials in the UK or the US, and I sort of have heard privately from people in UK as to some of the political reasons why that wasn't done. I knew that was going to be, I thought that was going to be bad because that not generating that evidence is just going to be a big problem later. And who would have thought we'd be in year 3 and we'd still be, and politics fills the evidence vacuum. When you don't generate evidence, then politics comes in. It's natural for that to happen. The other thing I think I'm different than other people on is, they always say that if it weren't for that man you cited, if it weren't for that, we wouldn't have had this. Of course, that's not, because of course, when you lock down society, like you've never done in history, some smart people will think it's a good idea. Some smart people will think it's a bad idea. And some smart people just won't know. That's the nature of anything that's unprecedented. There'll be a range of views. And so, if John didn't exist, they'd be someone else. And history may yet vindicate him, I think, in many respects, when we see double-digit inflation and the collapse of global food chains and starvation globally. So I think, I regret watching people demonize him at the time. And then the other things I regret along the way, that we could have done cluster randomized trials for NPIs. This Paxlovid, I think, this is the reversal point. We always see over and over, like financial conflict of interest plays a role. And right now, I don't think everything has a financial bias, but I certainly think the testing industrial complex has a huge bias. And there are professors who used to be at universities who now work for testing companies. And we're sold this mantra that like, all we need to do is test our way out of this. But if you really think about something that's going to eventually break through 98% of people, I don't know what this testing going to do. And what are you going to do if you're test positive? You're not going to be able to hang out in your house for however many days it takes. It's not realistic. And I also think that the Paxlovid and the boosting in perpetuity, that's another thing about medicine. Like something works wonderful. 2 doses in like an older person, that's like one of the best things we've ever done in biomedicine. But 3 doses in a 4-year-old, question mark, we can acknowledge there's always a spectrum of risk and absolute risks get low. But you see lower and lower evidence to debut the product in the population's least at risk. And that's kind of a classic reversal thing too, where, statins post-MI, high cholesterol, the, 4S, amazing. But, I just saw somebody tweet, John Mandrella said, should every 30-year-old take a statin? I don't know, really, or why not go, and why stop at 30? Go to 12, go to 5, go to 2, should we all take statins? These are tougher questions. And yet, if a little is, or if a little good, a lot is better. I think that's a recurring theme. But, I think, and my last point, my favorite thing about that second half of your talk was your point about that arguments will fill that evidence vacuum. And that's something we could have done better. And it's still not too late. But.
Yeah, I think you're right. I guess the one thing and I'll just say one last word. I've always, I think I sent you a back channel Twitter message about this. I've never seen myself as an advocate beyond advocating for my own patients. And I've gotten into all sorts of trouble, with that in the past. And a lot of people would say, well, it's because, you're lucky, you don't have to advocate, given your position and so forth. I think it's less that, and it's more just who I am. And I absolutely respect, the people who advocate for their causes. One of the hard things with COVID, I think, is that often, advocating for a way to go forward, those people sort of become true believers, and it becomes hard to have, a conversation about those things. And where if you discuss something that you think that there's not great evidence for, or that there's question, or that there's room for debate, maybe undermines the advocate's message. And it's made for some very uncomfortable situations through this. And I don't know if that's something we can avoid or not. That's where I'd leave us with a question.
Well, don't worry, those advocates, they'll bury the last scientist among us. They'll get the last one. Brilliant talk. Thank you so much for doing this. Thanks for the Q&A.
Thanks for having me.
So much of your time.
Thank you.
Real pleasure. Thank you so much.
Appreciate all the questions, guys, really. Have a good night.